morning, everybody. I'm just so elated to be here. For one thing, I'm from Michigan, so this is a very good break from going from weather to 30. We call it warm season. It was 40 when I left. We pray for that in February. And when Dr. Brookhart first asked me, I was like, okay, February the 12th for you guys is a nice day. In Michigan, I might not even be able to get out of the door, but it worked out. So I'm just so thankful to be here. I'm also honored to be here with distinguished men on our panel, especially Dr. Heflon, who just talked, and Dr. Liu are the writers of the article that my program is based on. They wrote an article called Racial Disparities in the African American community. And so the little clip of the video that I'm going to show you is based on our federal grant, and that was our research. And everyone in my program, in this program, Strong Beginnings, has to read that article. It's mandatory to work in this program. And also, Ms. Grant came and gave her testimony and her life story. She is a prime example of the African American woman that I would see in my outpatient practice, because she's educated, and she wouldn't be in my home base because that's all Medicaid based. But she shared some of the cultural issues that keep African American women out of services. We are a really close-knit, whatever happens in the family, you keep it in that family. So a lot of our needs don't get met because of those family secrets, and I'm so glad. I'm also endorsed infant mental health specialist, and those ghosts in the nurseries come out during that first pregnancy. So I'm going to talk a little bit about that. I'm going to have, and I can go real short and cut mine because Dr. Heffron talked a lot about what I'm going to be talking about. So I'm going to show a little bit of this video to help you to understand how life course affects African American infants.
Several years ago, two physicians in Chicago set out to solve a mystery. Why do African American women have babies that are born too small at twice the rate of white American women? Richard David and James Collins are neonatologists, pediatricians who specialize in the care of infants who come into the world too early or dangerously underweight, and often both. Like virtually everyone in their field, they were troubled by the striking racial differences in rates of premature and low birth weight babies. What could account for the differences?
I originally thought that the disparity in premature delivery was really driven by socioeconomic differences between African Americans and whites. It is well known that African Americans have a lower collectively socioeconomic status than whites, are less likely to receive college education than whites. So I thought once you corrected for that, that the gap would go away.
But Collins and David discovered the gap didn't go away.
We were very surprised to find that the gap actually widened as education and socioeconomic status improved. And then began to look at it from a bigger perspective and broader perspective, and really started to realize, well, maybe it's something about lifelong minority status, which is the driving factor here.
There's something about growing up as a black female in the United States that's not good for your childbearing health. I don't know how else to summarize it.
So the two neonatologists began to explore whether being a member of a particular minority group might affect pregnancy outcomes, and they came up with a controversial hypothesis. What's behind the low birth weight and premature birth for African American babies is the unequal treatment of African Americans in American society. In other words, racism is taking a heavy toll on African American children even before they leave their mother's wombs. It's an idea that's slowly gaining acceptance.
We're in the midst of a paradigm shift. 15 years ago, racism as a risk factor was almost never heard of in a scientific paper, whereas now it's much more a possibility.
this is a lawyer, and she had a low birth weight baby, and she was educated at first when I first started in Strong Beginnings, and I heard all of this, and I was like, no, that's only for the Medicaid people. Of course, someone like me with a PhD, I would never have a low birth weight baby. I wouldn't have toxic racial stress until I went to Dr. Liu's training that is also mandatory for our program, and heard him speak and helped him to help me to understand that life course of being unfairly treated, it doesn't matter whether you have a PhD or whether you didn't graduate. It's still some things in America that affect African American women, and it also affects when we have our children. So I'm going to talk a little bit about the program that it's a National Federal Healthy Start program that was developed in Grand Rapids, Michigan, where I'm from. And I developed this model to basically help me as a therapist. We have community health workers and teaming up together where they took care of all of the resources, because as an in-home person, if I go, even though I have a PhD, and they don't have heat in Michigan now, today, if I went to a client and she didn't have heat, asking her how she feels about her relationship with her baby and all of this, she's going to say, excuse me, don't you feel it's cold in here? So even with a PhD, my responsibility would be to call the neighborhood health department, different areas, have that list of people that help with gas bills so that the gas could get on so that the baby will feel comfortable with his mom. But the team model that I created, the approach, the holistic approach, they have that taken care of through their community health worker. So all I would have to do if they didn't have minutes, if they had an Obama phone that wasn't working, here's my cell phone, let's call your community health worker. She's going to take care of that. Now I can take care of the stress of how you feel inadequate of not being able to provide your health care and the heat that your child needs right now. So that's a little bit about the model. And so I'm going to go through a little bit of the research to kind of help you to understand what African American women, what we go through. Okay, and I'm just going to just paraphrase a little bit of them. But like I said, the article that said there's multiple research studies that examine racial and ethnic disparities in birth outcomes. The perceived racism as a stressor over lifetime, which is life course, has been shown as a predictor of preterm and low birth weight births. And those are the two major high risks that cause African American babies to die, in all babies, but ours at a higher rate. And then racism as a primary stressor for African Americans, the perception of being made to feel inferior promotes an emotional and physiological response which could potentially shorten that pregnancy, that preterm birth. And they also said that there wasn't any type of disparity when you looked at class, race, education. In fact, they said some of the higher level educated women had more concern because, for one reason, emotionally, we feel like we shouldn't be treated like that because we may feel like we're up here and that we're equal. And so, or the stress may be a little bit more because they're in jobs that would be stressful for any women. So there's a lot of different research that's going on with that. So I'm going to talk to you about Strong Beginnings and present this holistic approach that I developed to address some of these issues. Just some other studies, pregnant African American women experience a higher number of life events, and the majority of their life events are distressful. They're not like graduations and weddings that are the lovely kind of stress. My daughter's getting married in July, so I'm going through some of that stress. That's the good stress that we go through. The stress that they have is the de-stress that no one wants to go through. And then African Americans women living in poverty are exposed to more chronic stress over and over again, and they don't have the resources to manage it, that dollar bill to manage it. And we know that when stress is not managed properly, then it turns into depression or perinatal mood disorder. And then evidence also shows that women that are disadvantaged by racial or ethnic minority status are more likely to have depression than any other population in the United States. We go through a lot, African American women. African American women experience depression at a greater level of severity and persistence. They're often, in the community in general, there's misdiagnosis and undertreatment of depression, and only 12% of African American women seek or remain in treatment in the traditional mental health or substance abuse disorder settings. Also showed, this is a study in Iowa that showed that women suffer postpartum depression more higher level than wealthier women. And then Johns Hopkins talks about partnership at that time. Domestic violence is higher for African American pregnant women. And it shows that the greater level of postpartum depression results if you have experienced domestic violence during your pregnancy, and 1 out of every 3 women who are pregnant develop depression in the first 12 months if they've experienced some type of domestic violence. And then as Dr. Heflin talked about, when the mothers have that maternal depression, when their social, economic, biopsychosocial environment is not the way it should be, that it affects their children. It affects their birth outcomes. The babies are more irritable. They're more likely to be abused. If you have a mother that's stressed and then the baby is irritable and crying, sleep problems. Also, it affects behavioral problems and also gives them a lot of ACE types of experience that we talk a lot about in all of the programs that I supervise. And that negative parenting results in inconsistent corporal discipline and just not emotional sensitivity that a child needs to grow up to be happy and successful. Studies further suggest that there are practical barriers that keep African American women from engaging in services, psychological and clinical barriers, and also cultural barriers. And so my program is designed to reduce some of these, and I'm just going to go through these really fast. Lack of insurance, even with Obamacare, I don't know how it is in California, but in Michigan, you still have a hard time accessing it. It's there, but getting it to work for you to get your mental health needs is still not fixed yet. So we're still working on that. I laugh a lot and I say it's like having $1 million in your checking account, but forgetting your PIN. You can't get access to it, even though it's there. Lack of transportation was a barrier for a lot of the women, African American women in our community, because our program, most of the women live in the inner city, and most of our mental health services, of course, are in the suburban area. So you would have to have money to come every Thursday at 4 o'clock to our outpatient center, or you would have to have access to a bus, transportation, and different things like that, and that doesn't work for this population. Then lack of child care and other competing priorities. Most of our moms may be pregnant, but they also have a 3-year-old that's on the Head Start bus that they have to be there, or they have a school-age child that has to come home and they have to be there. There's limited clinical hours. Most of our outpatient services are provided from 8 to 5, which may not fit into, especially our working moms. They don't have flexibility where they have flex time where they can leave an hour and go for a counseling session. Fear of ruining their career and losing their employment. A lot of people do not want their employer to know that they have depression, even postpartum depression. Lack of knowledge on how their mental health affects their physical health. and their social functioning. And that's what's so good about my program, is that we combine that physical health as well as that mental health, and helping them to understand that if you're stressful, it affects your blood pressure, it affects diabetes. It affects your ability to be nice to your neighbors or your partners or your children when you're not feeling the best emotionally. Okay, and then some of the psychological and clinical barriers is that stigma. And stigma is strong for a lot of people with mental illness, but in the African American culture, I'm not crazy, I'm not mentally retarded. And do not give me any of those crazy pills, no medication. African American women worry about what others will think of them if they do seek treatment. They're lazy, they're weak, they're unmotivated, and but we also have Network 180 is our community mental health program, where is the gate where they have to go to sign up for services if they have Medicaid. Now, they've created this beautiful new building to try to despair and make people inviting to come to Network 180 to get their things that they need to be referred to our agency, Arbor Circle. But they placed it in a place where on one side is the community resource complex where they would go if they didn't have heat today in Michigan, or if they didn't have food or diapers. And then on the other side of our community mental health is our health department, where their neighbors may be going in to get their WIC or get their immunizations. Now, do you think they're more likely to go to this brand new building now, or less likely to go to this building, knowing that one of their neighbors could be getting their gas bill paid or getting their child shot, and see them go? Everybody knows what Network 180 means. Even though now it's a beautiful orange building, it's still Network 180 Community Mental Health. So those are some of the system things that keep women, anybody, from getting mental health services. Many of the African American women have multiple factors and life experiences that contribute to their stress and their depression, so we don't know what to treat first. Also, many of them, like many women, do not want to deal with past physical or sexual abuse. They're embarrassed. I shouldn't have been hurt like that as a child, many of them say. Many clinical treatment models and assessments are not culturally sensitive to people of color. Talk therapy alone is not always effective. I heard Peg say that earlier, that talk therapy is only one way to deal with what people are going through. A number of treatment sessions are not adequate to fully address clinical issues. If you're on Medicaid, you get anywhere between 6 and 20 sessions. 20 sessions if you have priority health Medicaid. Everyone else is 6 to 12. It takes 6 to 12 issues just to develop a relationship, and then it's time to close. There are fewer professionals of color and professionals who are experts or have experience engaging this population. Now, this is Grand Rapids, Michigan. This is a very conservative, middle-class city. But now if you go like 200 miles east of Grand Rapids, where Detroit is, some of these issues are addressed differently, because there's a lot of African American professionals in Detroit. Engagement is key. When you're talking about treating any minorities, especially African Americans, that trustworthiness. Can I develop a relationship with someone? Can I share with them? Many of our mothers are still Medicaid based, are still have a relationship or a past relationship. Either they were in foster care or their children have been in foster care. So they still have that feeling that if I share how I really feel, they're going to remove my children. They're going to call CPS and tell them that my father molested me or my boyfriend beat me up last night. So that trustworthiness is not there. And then some of our cultural barriers. Traditionally, the African American culture in in general has not embraced mental health services. Many African Americans deny mental illness. They say black people don't get depressed. I'm too blessed to be stressed. Many prefer treating symptoms with alcohol or illegal drugs instead of psychotropic medication. In our state, we just got approved for medical marijuana, but many of my young in-home mothers, marijuana is their psychotropic medication. Some religious beliefs can also be barriers to receiving services. Just pray about it. And I always tell my clients, yes, I believe in Jesus, and you can pray that you get a good therapist and the right medication so that you can socially function. So what works in Grand Rapids? Strong Beginnings, which is a federally Healthy Start funded program. I'm mandated to say this if I want to keep getting the money for my program. Not just because I created the model, but because I have been experienced in my community. I've been there for almost 60 years, hate to say that. And so I knew what was needed in my community. I knew what was keeping my clients and my relatives and my neighbors from getting services. So the powers that be allow me to do it. And this is one of the reasons why they keep allowing me to do it. In 2005 to 2009, outcomes at our Healthy Start project showed a completion rate of 98.5% for clients referred for mental health services. During that period, 260 of the 264 women referred for depression engaged in treatment. Among the 330 women served in individual counseling or therapeutic groups, as of March 2012, 90% completed their referral rate, and the average in our community is 50%. It was an 18% no-show rate, which is 55 for all of our mental health clients in my agency. 92% completed the program and met their treatment goals. 95% of the pregnant women who had substance abuse issues stayed clean until delivery. And then depression and stress scores reduced 20 to 50%. So why does Strong Beginnings work? Strong Beginnings works because we have a term in the African American community that's called FUBU. And FUBU means for us, by us. So Strong Beginnings was created for African American childbearing women and their infants, and it was created by an African American woman, which was me. And so how our community health, Network 180, was a partner in our collaborative from the beginning. The collaborative recognized and supported the need for mental health services. A lot of times, because our fiduciary is one of our large hospitals, and a lot of times they want to deal with the physical part of that pregnancy, getting them prenatal care and all of that, nutrition, getting them on WIC, but they did not want to deal with the mental health part of it. The mental health positions are part of the collaborative. I received support from the collaborative in my agency because I had worked in my communities for years. They trusted me. They said, here, whatever you need, and they allowed me to design it. As an African American mental health professional, I was aware of the barriers and the treatment in our community and designed the program to reduce them. So some of the ways, I'm just going to go through this fast because I know we got some famous people that I'm waiting to hear. Free to all women pregnant or parenting an African American child under 2. They do not have to be, the mother does not have to be African American, the child. So we have Caucasian and Hispanic women in our program. We provide home-based group, outpatient therapy. Appointments are set around their schedule, and services are available to them until that child reaches 2. So that gives you a long, intensive amount of time. And education on mental health is provided first. We normalize it so that they understand. Multidisciplinary team approach is now universal. I did not know anything about this. I did this so that I could do the therapy work that I wanted to do instead of worrying about heat and gas and lights and housing. I could deal with the issues and the strategies and give them what they need so they can get out of that cycle of not having their needs met for them and their children. But now it's universal, where you provide a team. And our program has been so successful, and I'm gonna share a little bit about how it's expanded now, that we even have OBYGs on it. A lot of primary physicians, psychiatrists are all, because of they know the effect that postpartum depression and other mental illness in women, how it affects them as a provider and how it affects that family. Okay, and in our model, some of the strategies that we use, the community health workers and I, as the therapist, or my other therapists now, work as a team. The community health workers, there's a lot of push now for peer people. They are the peers. They go in, they do their health part, they do their community resources, they engage and develop that relationship. I have trained them on the symptoms, the referral process, and the do's and don'ts for this population. We go together for the first session. They present me as part of their team. Most of the time I tell them, don't present me as Dr. Morgan. Present me as Marguerite, someone that's going to come and help them. Because once you say doctor, then you know that's a little bit different level. I want to be a person that's coming in to help them with their mental health. Initially, we don't use a lot of psychological language, psychobabble as my husband calls it. I focus on their feelings and their behaviors. I develop that relationship. I love the Edinburgh because it addresses how they're feeling. It's in a language that they understand, and that really helps for me to have a gateway in. We provide individual and group treatment. We have a SAD group, which seasonal affective disorder may not affect you guys, but that starts next Tuesday in Grand Rapids. We have a stress management group that any woman in America would love. We just pamper ourselves. It's called Relax, Relate, and Release. And then we do anger management, because we also, in Michigan, have a high level of African American infants that are in the child welfare system, and most of those mothers are angry. And so all of our groups have been approved through our family court division. And then we do a lot of grief and loss, because the mothers have either lost due to death or to the child welfare system. And then we also have a weight management one that talks about how their mood affects what they eat. And that's very popular after you've had that baby and you can't zip up those jeans. That makes any woman have some type of mood disorder. And the community health workers manage all of the resources, so I can focus and my therapist can focus on clinical issues. We use clinical treatment models and assessments that are adaptable to our culture and population-specific issues. Confidentiality and boundaries issues are foremost, because Grand Rapids is a very small community. Accepting them where they are clinically. We don't have to rush through it like you do in an outpatient setting. And reducing some of the cultural barriers. We are all women of color who have a passion for working with other women of color and their families. But I have to say this too, you don't have to be African American to engage African American families. You have to be trustworthy, and you have to have a passion and desire and understanding of what they're going through. So color has no issue. We just were able to get this grant, and we have we are experts at working through the cultural resistance and ambivalence about mental health and substance abuse services. And we know how to appropriately use cultural, religious beliefs and values for treating women of color, because Grand Rapids is also a very Christian-based church on every corner environment. So no matter what population you're serving in Grand Rapids, there's going to be a high Christian involvement. Also, some of the clinical approaches, I am a proponent of cognitive behavioral therapy. The way you think is the way you behave. That's how I feel. We also have a program called Lives That Bind, and it's a cognitive restructuring program developed by another one of my colleagues. And that works on that childhood, reenacting all of your trauma and different things, and that's been very effective with this population. We also are all trauma-informed therapists. The Ms. Grant who talked today talked about some of her trauma, bereavement, and we have multiple losses. We just don't talk about death, because many of my young clients, when I started, they all kept on telling me, I've lost the American dream, the American dream. I was like, okay, well, tell me, what does that mean? They still, in 2015, women still want the knight in shining armor and the house with the white picket fence. Hasn't changed since I was growing up. And they don't have that. A lot of them don't have the things that they want for their children and the stuff that they see on TV. We also do a lot of reality therapy with our child welfare moms. It's black and white. You do it, you get your kids back. You don't, they're not coming home. So we do a lot with that. Motivational interviewing is really good with this population because of the open-ended type of question. You know, they can be free to answer. We are all infant mental health-based therapists. So when those ghosts in the nurseries come up, we know how to manage that. We focus a lot on the parent-child attachment relationships, a lot on the ACE, different things. I'm so happy to meet you today. All of my programs, I supervise 13 programs, and all of them have, we have Dr. Folletti's ACE type of experiences to help these women those experiences and improve the life experiences of their child. We also do a lot of life skills, empowering, problem solving, coping, which I call mothering. A lot of my clients need a grandmother, a mother, and a big sister in order for them to improve. Individual and group therapy. I also do outpatient for, because postpartum depression affects any mother, and a lot of the mothers who are educated and have regular insurance and not the Medicaid prefer to see me in outpatient. The groups are very effective because they support each other, but they also allow me and my staff to see them one-on-one and they're non-threatening. And even if we tell them initially, okay, you may have this, you may have signs of depression, they're not going to hear it. After the group, they come up and they're like, yeah, you're right. Depression. So the group is a very good way to engage them. We focus a lot on perinatal mood, anxiety, because of the post-traumatic stress that many of them have experienced, the trauma, and then the life stressors of poverty, domestic violence, and racial issues. And the Relax, Relate, Release is a stress management group. And then in ending, we have expanded our programs because of the numbers that I showed you with our original one. We started with just inner city moms. Now our program has expanded to the entire county. We also have familial, Wentes, Salaba. I had to learn how to say this. We've expanded this. If anybody's bilingual, they probably say, what is she saying? Anyway, our motto now is to Latino families, and that means healthy and strong families. And then, and because we had a lot of my Hispanic staff, when I presented on Strong Beginnings, they came up and they're like, Marguerite, you need Strong Beginnings for Latino families because we have immigration issues, we have the toxic stress, we are isolated. And I said, okay. So we went and we got that. Then we had the fathers complain. They was like, Marguerite, I love you, but I have no desire to sit in a session with you and my wife. So I need a man. And so now we have expanded. I have a whole team of men, community health workers, as well as therapists, together with the fathers. And then we also had complaints because I also see Caucasian people, and they're like, well, how come that's reverse discrimination, Marguerite? How come I can't be in Strong Beginnings? That's it. And so now we have expanded it through our ARC program that we can serve any My Hip family who is not in Strong Beginnings. So I hope that this has been helpful to you. And If anybody is interested, that's my contact information on how you can adapt it to your community. Thank you so much.